Hi, welcome to Nursing 542, Module 5, lecture on the management of pulmonary conditions in the primary care setting. Start out with upper respiratory infection management. You see the goals of treatment are relief of symptoms and avoidance of complications, especially in the patients with comorbidities. Treatment. Rest, fluid, antipyretics, and analgesics is needed. Antiviral is appropriate. And here's the biggie, antibiotics are not indicated. Approximately 50% of providers prescribe antibiotics for upper respiratory infections. Such practices are thought to contribute to the issue of antimicrobial resistance. For influenza patients, antivirals such as Tamiflu can be instituted within 48 hours of symptom onset and is recommended particularly for patients at higher risk of complications. Antihistamine or decongestant use remains controversial. Some studies have shown positive impact on duration of symptoms. I would caution you against the use of decongestants in elderly patients, as decongestants may contribute to hypertension. Use of nasal decongestants beyond 3 days may result in rebound symptoms. Some studies have shown zinc to decrease the duration of symptoms. However, other studies have shown no benefit. There are side effects such as permanent loss of smell that have been attributed to the use of zinc. There is not conclusive evidence to support that the use of any herbal or vitamin treatments positively impact duration of upper respiratory infection symptoms. As far as your upper respiratory infection management, typically self-limiting, you want to avoid, hopefully, for your patients, the complications that can occur. Patients should be seen for follow-up if symptoms persist beyond 7 days or progress. At that point, a secondary bacterial infection should be assessed for and treated if present. All patients should be educated on hand washing as preventive measure. Patients with comorbidities should be advised to receive the flu vaccine yearly and a pneumococcal vaccine. Acute bronchitis, it frequently occurs with upper respiratory infections, and the treatments are similar: rest, fluids, and over-the-counter medications for comfort. Again, antibiotics are not indicated, just symptom management is the goal. Asthma, goals of treatment here listed: reduce symptoms, avoid exacerbations and complications, maintain normal activity level for your patients as possible, prevent loss of lung function, and minimize side effects from medication. And the treatment recommendations for asthma are based on the level of severity of disease. Asthma patients must be monitored regularly to determine effectiveness of their treatment and their level of control of disease. Asthma management, please see the EPR3 PDF I posted under this week's readings. It gives a comprehensive explanation of how to adjust treatment up or down based on the patient's symptom control level and a stepwise approach. Asthma patients require follow-up every 1 to 6 months, depending upon the severity of their disease. Patients should return to clinic for evaluation in 1 week following an exacerbation. Each visit should include assessment of their symptoms and lung function, determination of appropriate use of medications and monitoring devices, and evaluation of patient satisfaction with treatment regime. As with many chronic diseases, patient education is key to successful management of asthma. Patient education should also be addressed at each follow-up visit. The patient needs to know how to monitor their symptoms and lung function, how to appropriately take their medications, how to avoid exposure to triggers, and when to seek treatment. Typically, self-monitoring is done via peak expiratory flow measurement. These devices are inexpensive, however, results are dependent upon proper technique and patient effort. You will need to confirm that the patient is utilizing the device appropriately. A written asthma action plan developed in coordination with the patient is included in the National Asthma Education and Prevention Program, EPR3 recommendations. Patients with asthma should be advised to be vaccinated annually for influenza and to receive the pneumococcal vaccine. The treatment recommendations posted in this week's readings outline both the needs to step up or increase treatment in order to control asthma symptoms and the need to step down or decrease pharmacologic treatment once asthma is well controlled for 3 months. Prior to increasing treatment, you should confirm that patient has been utilizing the inhaler correctly, taking medications as prescribed, and controlling environmental factors appropriately. Referral to a consultation with the pulmonologist is appropriate if the patient requires step 3 or 4 level treatment. It is important to maintain the asthmatic patient on the fewest medications at the lowest doses possible in order to decrease the likelihood of side effects related to medication use. The medications listed here are those typically utilized in the management of asthma, as indicated in the treatment recommendations document in this week's readings. Short-acting beta agonists can cause side effects of tremors or tremulousness, palpitations, and anxiety. Utilization of a spacer may help with proper inhalation techniques. Low, medium, and high dose inhaled corticosteroids may cause hoarseness and or oropharyngeal candidiasis. Use of a spacer and rinsing mouth and throat with water after each use may decrease the risk of these side effects. Evidence of inhaled corticosteroids causing systemic side effects such as adrenal suppression, increased risk of lung infections such as pneumonia and TB, increased intraocular pressure and development of cataracts, growth impairment in children, and osteoporosis in adults and children, and impaired glucose metabolism, insulin resistance is inconsistent. These side effects are known to be related to oral corticosteroid use, and some studies have correlated their occurrence with inhaled corticosteroids, particularly high-dose inhaled corticosteroids. There are no long-term studies with control documenting safety in pregnancy. However, the benefits of controlling asthma in pregnancy are thought to outweigh the risks associated with inhaled corticosteroids. Monotherapy with long-acting beta agonist is not recommended. Long-term beta agonists are shown to increase symptom control and improve pulmonary function. However, there is some concern of increased risk of fatal and near-fatal asthma exacerbations among a small subset of patients. Again, patient education regarding the proper use of these medications and their potential side effects is crucial to effective management and minimization of side effects. You'll need to be able to recognize the signs of impending respiratory failure, as I briefly mentioned in the previous lecture. Some or all of these may be present. There may not be wheezing. Breath sounds may be barely, if at all, audible. PEF less than 50% of baseline indicates serious exacerbation. Hypoxemia indicates life-threatening asthma exacerbation or other diagnosis. Treatment for a patient with asthma exacerbation and symptoms of impending respiratory failure in the primary care setting include calling 911, administering oxygen, providing repeated bronchodilator treatments via nebulizer if the patient is unable to effectively utilize MDI, and epinephrine IM or sub-Q. Pneumonia management. The CRB65 tool can be used along with clinical judgment to determine if hospitalization is appropriate for patients with pneumonia. The C is confusion, R respiratory, and B what their blood pressure is. So this is a good tool to have if you're outpatient setting. Outpatient treatment for adults with no known comorbidities or risk for drug-resistant strains should be treated with macrolide or doxycycline. In parts of the United States, there are areas where greater than 25% of the pneumonia is macrolide or doxycycline resistant. In those areas, the fluoroquinolone therapy should be considered. Both macrolides and fluoroquinolones can contribute to prolonged QT waves, and fluoroquinolones are also associated with greater risk of C. diff. So you'll need to weigh the pros and cons of each of these, as well as individuals' patients' health status and risk factors when choosing which antibiotic you're going to utilize. Most previously healthy adult patients will respond well to treatment and recover without complication from pneumonia. All patients should be seen for follow-up in a week to confirm response to treatment. No routine follow-up chest x-ray is indicated except in smokers to rule out any underlying contributing factors such as cancer. Patients with pre-existing comorbidities and at risk for complications should receive more comprehensive treatment and follow-up. For example, frail patients may require nutritional education, consultation, and physical therapy to regain the strength lost following a bout with pneumonia. All patients should be instructed to return to clinic or call if symptoms are not improving after 3 days of treatment or if their symptoms worsen. Patients with significant comorbidities are at risk of exacerbation of those comorbidities and should be monitored appropriately. Patients with chronic illness or at high risk of complications should be advised to receive the pneumococcal vaccination. COPD management. Symptoms can be assessed via the CAT or the MRC tools. Degree of airflow limitation is determined via spirometry and graded based on the GOLD staging system, as shown on a subsequent slide. The risk of exacerbations is based on history of exacerbations and hospitalizations, as well as severity of airflow limitation. There are various COPD dyspnea assessment tools in existence. I was unable to access the CAT one. The MMRC is based on the patient's report of dyspnea, as you'll see here. This is the GOLD staging system developed by the Global Initiative for COPD, which grades COPD based on spirometry results. This is a criteria for high risk of COPD exacerbations according to the Global Initiative for COPD's most recent report from 2015. 2 or more exacerbations within the last year, or an FEV1 less than 50% predicted value, or 1 or more hospitalizations for COPD exacerbations. Put someone into the high-risk category. These categories by the GOLD are based on the combined assessment of symptoms, the GOLD staging, and the risk for exacerbations. This takes the 3 together and combines them to categorize the severity of their COPD. COPD management in the primary care setting. I want to definitely address smoking cessation. It has the greatest potential to positively influence the COPD progression. All of us should encourage all patients who smoke to quit. Healthcare provider encouragement to quit has been shown to significantly improve the cessation rates. Nicotine replacement and pharmacotherapy have also been shown to improve cessation rates and should be offered routinely to patients that smoke. Reduction of exposures to other toxins at the workplace or other environment is important to stress as well. Regular physical activity is beneficial for all COPD patients. Encouragement to remain as active as possible should be included in each follow-up appointment for COPD. Pharmacologic treatments currently utilized for COPD have not been conclusively shown to impact the long-term lung function or decline in COPD patients. All COPD patients should be advised to receive the pneumococcal and influenza vaccines. As noted on the slide, even though the current treatments, pharmacologic treatments, aren't shown to or proven to impact the long-term lung function, they do help patients have improved health status, activity, tolerance, and quality of life. So that's why we bother with that. These are the classes of medications and combinations of medications recommended for the management of COPD. The choice of medications is based on availability of medication and the individual patient's severity of disease and response to medications. Bronchodilators are central to COPD symptom management. Beta-2 agonists, anticholinergics, theophylline, or a combination are principal bronchodilator treatments used for COPD. Long-term treatment with inhaled corticosteroids in combination with long-acting inhaled bronchodilators is recommended for patients at high risk of exacerbations. Long-term monotherapy with inhaled corticosteroids is not recommended in COPD. Inhaled corticosteroids place patients at greater risk for pneumonia, and withdrawal from inhaled corticosteroids may trigger exacerbation in some COPD patients. Combining long-acting bronchodilator with inhaled corticosteroid places patient at even greater risk of pneumonia. Although oral corticosteroids may be used for short-term treatment of exacerbations, their chronic use should be avoided. In patients with severe or very severe COPD, history of exacerbations, and chronic bronchitis, the phosphodiesterase 4 inhibitor Flumelast has been shown to reduce exacerbations requiring treatment with oral corticosteroids. This slide outlines the first-line treatment recommendations for each level of disease according to the GOLD initiative. The SABA is a short-acting beta-2 agonist. SAMA is a short-acting muscarinic receptor antagonist, the anticholinergics. And LABA is the long-acting beta-2 agonist, and LAMA is the long-acting anticholinergic. Theophylline has been shown to improve the FEV1 and breathlessness when utilized in combination with the long-acting anticholinergic versus the long-acting anticholinergic alone. Advanced care planning discussions should be included as part of your COPD management plan. Short-acting inhaled beta-2 agonists with or without short-acting anticholinergics are preferred treatments for COPD exacerbation. Systemic corticosteroids and antibiotics can shorten recovery time, improve lung function, and lower the risk of early relapse and treatment failure. Lung cancer management. The primary management of lung cancer will be performed by some or all of the above listed specialists, or the specialists listed on the slide here. I would urge you to consult with a medical oncologist or pulmonologist if you have a patient with symptoms and chest x-rays suggestive of lung cancer. They can advise you on the further workup that they would like you to do regarding labs, imaging, etc. And that way you can avoid duplication, and the specialist will have the information that they're seeking at the patient's first appointment. Once a patient of yours has been diagnosed with lung cancer, your primary role will be to manage their comorbidities. You will want to consult with the specialist treating the patient to make sure they are aware of your treatments. You will also want to assess your patient for secondary depression or anxiety related to their diagnosis. Typically, with pulmonologists will be consulted for patients in whom restrictive lung disease is suspected. Treatment will vary depending upon the underlying etiology. In primary care, your role will be to treat the patient's comorbidities, assess for treatment side effects and disease complications such as right-sided heart failure or pulmonary hypertension. You'll also want to provide the patient education regarding the disease process, avoidance of exposures, and immunizations. Also, as with any patient with a new chronic disease diagnosis, you will want to screen for depression. Pulmonary embolism management. Patients will typically need to be supported until they can be transported urgently to an acute care setting, emergency department. There they will be treated with IV anticoagulants, typically heparin, unless they have contraindications for anticoagulation, such as active GI bleed or hemorrhagic stroke. Patients in whom anticoagulants are contraindicated may be treated with placement of a vena cava filter, thrombolysis, or embolectomy. But that, of course, will not be under the primary care provider's direction. What will be under your direction frequently is the management of patients who are on long-term anticoagulant therapies. You will monitor their international normalized ratio, the INR, and typically adjust their dose to keep it between 2 and 3. You will need to assess the patient for recurrence of PE and for bleeding complications. Patient education regarding avoidance of PE risk factors, signs of bleeding to report, dietary consistency with foods high in vitamin K, importance of regular blood tests, and avoidance of high-risk activities should be provided by the primary care provider. Tuberculosis is a reportable disease, meaning that as a provider, you're required to report cases to the public health agency. It is typically the public health district that provides treatment and addresses compliance and surveillance issues. You would screen any patient, any TB positive patient for HIV. You may draw labs of liver function, bilirubin, CBC, BUN, creatinine, and serum uric acid prior to treatment initiation. You would also perform visual acuity screening and test for red-green discrimination, as one of the drugs that recommended for TB-EMB can cause ocular toxicity. Again, some of this pre-testing prior to initiating therapy may be done by the public health district, but you'll want to check with them to avoid duplication. Current CDC recommendations for treatment of new active TB include combination therapy for 2 months with the 4 drugs of INH, niacid, INH, rivampin, pyrazidamide, PZA, and ethambutol, EMB. So thank goodness they all have the little acronyms. Followed by a 4-month course of INH and RIF. If cultures are not negative at 3 months, then drug-resistant TB would be suspected. As a primary care provider, you will want to educate your patient regarding the importance of completion of the treatment regime, potential complications of TB, and possible side effects, drug side effects. Complications of TB include pneumothorax, bronchiectasis, pulmonary destruction / respiratory failure. Treatment of latent TB, while still typically managed by the health department, will be something that you'll be more apt to see in primary care. Recommendations are for 9 months of INH or 4 months of RIF. As a primary care provider, your role will again be to monitor the patient for any treatment side effects such as hepatic toxicity, liver toxicity, and to educate your patient on the importance of compliance with and completion of their treatment regime. Again, I know these modules, these lectures cover a great deal of information. It can be overwhelming. There are several of the pulmonary disease management references located in both the assigned and optional reading sections of this week's module for your use.